Hello, this video will discuss some of the results of Protocol T from the drcr.net concerning the use of anti-VEGF drugs in management of diabetic macular edema. The three drugs were compared in this trial. I would like to acknowledge my younger colleagues, especially Muhammad Ashraf al-Masri. The publication of the results of Protocol T was already out in the New England Journal of Medicine, and the design was giving the three drugs in the default dose, which is acknowledged worldwide to be used, with the use of 0.3 milligrams of ranibizumab because it is the FDA approved dosage in diabetic macular edema. At the baseline visits, all patients would receive intravitreal injection according to the group and the drug. And then a PRN protocol for retreatment was used. In general, an eye will continue to receive an injection if it is showing improvement on OCT and visual acuity. So if we show improvement, we continue to inject the medicine monthly. When we have some stability as regards visual acuity, the eye should receive another additional injection having a stable vision over the last month. This diagram shows the protocol, showing that you are giving a drug and then after 1 month with some improvement in vision, you re-inject, further improvement in vision, then you re-inject until you get a stable visual acuity, and at that point you also inject an additional injection, and after 1 month with again stable visual acuity, you stop and refrain from injection. There was a threshold of the thickness of the macular edema at which we considered this thickness as the norm. This was the threshold to enroll in the study and also the threshold to stop injection if we reach this level of dryness early in the protocol. So, within the first 24 weeks, if the eye has a very good central subfield thickness, meeting the threshold criteria described, and very good visual acuity of 20/20 or better, we would defer injection and stop early. But if the eye did not improve with this level of improvement described, with some edema still present above the threshold on OCT, then we continue injecting every 4 weeks until we reach the 24 weeks mark. After the 24 weeks, the injection can be deferred if there is stability in visual acuity. Revising it again on this curve, you can see when you reach a stable visual acuity, you inject once more, and then you have 2 months of the same visual acuity, the stable OCT. Then you can defer injection if you are beyond 24 weeks in Protocol T. When do we retreat? When there is a drop in visual acuity related to an increase in the OCT thickness, we start treatment again. And again, there should be some improvement in vision, and once stability is reached, we inject once more, and going for 3 consecutive visits at the same visual acuity, over 2 months period of stability, we stop injecting and we monitor and follow up. This diagram shows when to take the decision to inject and when to defer. Deferred laser was done after 24 weeks according to the discretion of the investigator. This diagram shows when you should do this. It is always after 24 weeks of treatment, always deferred, and the threshold of applying the laser is very similar to the threshold criteria of having a normal thickness in the fovea. How did the three drugs fare against each other? Well, the first year showed very similar changes in visual acuity, all drugs showing some gain in vision, which was maintained by this protocol throughout 52 weeks of the study. One salient hallmark of the Protocol T that the overall visual acuity of the three groups could actually go beyond the ceiling achieved by all previous studies, and it was then proposed that maybe every patient cannot exceed the 70 letters visual acuity, no matter how good was the visual acuity before injections and after maintaining any protocol, even monthly protocols of the rise and ride. However, using protocol T criteria, we could break this ceiling and have more visual acuities, higher vision in the three groups of the three drugs. You can see here that each drug was compared to the other, and ranibizumab showed similar data to bevacizumab. So Lucentis was very close to Avastin without statistical difference in mean visual acuity at the end of the first year, patients showing improvement, or even patients showing worsening. They were very similar. If you compare aflibercept to ranibizumab, it was very close without statistical differences concerning patients' improvement or patients' worsening. However, there was a better mean visual acuity of a few letters only. So, as regards the aflibercept compared to bevacizumab, well, more patients showed improvement of 10 or 15 letters, and of course a better mean visual acuity similar to the Lucentis data. However, there was no statistical differences concerning patients worsening, so no patients were worse using either drug. If we stratify patients according to their initial visual acuity at the entry of the study, we can see that patients with good visual acuity behaved similarly in the three drugs in the dotted curves underneath. However, if you see the group of patients showing vision less than 20/40, which is less than 6/12, you can see how the aflibercept drug showed more visual acuity gain in comparison to the other two. You can see here if we compare aflibercept or ranibizumab to Avastin bevacizumab. So, looking at Lucentis versus Avastin here, you can see that most of the data are not statistically significant. However, if you look also at worsening or worsening of patients, if you are using bevacizumab versus Eylea, again, no patient was doing worse. If we look at improvements, you can see that Eylea versus Avastin showed more patients showing improvement. So it did show better results as regards the improvement in visual acuity if you use the Eylea. Okay, let's have a look at the improvement of patients more than 10 letters, which is a lot of improvement. You can see that it was statistically significant again, which means more patients gain vision if you use Avastin. Also, the improvement was better if you use the Eylea versus the ranibizumab in patients with lower visual acuity below 6/12 or 20/40. So again, Eylea was behaving as the best drug in the first year of the protocol. But patients more than the 20/40 visual acuity mark were behaving similarly in the three drug groups. If we look at the changes in visual acuity, comparing different visual acuities at entry of the study, you can see that the three lines are close in higher visual acuity patients, and they tend to diverge in lower visual acuity patients, more favoring of the Eylea group. How about anatomy, the thickness? Well, if we look at aflibercept against Avastin, bevacizumab, of course it was behaving much better, meaning better thinning of the fovea was seen. Again, Lucentis showed much better anatomical result than the bevacizumab Avastin. How about both good drugs in comparison to each other? You can see that there was no statistical difference as regards the change in thickness, the improvement in the anatomy was similar in either Eylea or Lucentis. However, a bit more patients showed filling up to the normality point in the group of aflibercept. This was not a significant finding in the study in our opinion, and it is seen here in the curves. You can see that the bevacizumab shows thicker retina, and the aflibercept and Lucentis ranibizumab are very similar curves underneath here. If you look at change in thickness according to baseline visual acuity, the dotted lines are the better vision patients, and you can see that the two drugs, aflibercept and ranibizumab, are very similar, but the bevacizumab red dotted line was not so good in anatomy. The three curves and the continuous lines here underneath are a little bit different from each other, with aflibercept being the best, Lucentis a bit better than Avastin, and a bit less than the aflibercept. So both drugs were behaving better than the bevacizumab Avastin. In conclusion, aflibercept and ranibizumab are a bit better than bevacizumab anatomically, and both drugs are very similar in comparison to each other. Visually, all three drugs are similar if you have high visual acuity, but if the visual acuity is lower, the first year is favoring the use of aflibercept, first year data we mean. And ranibizumab and bevacizumab are quite close to each other. How about the number of injections? Well, they were very similar in the three drug groups, 9.2, 9.7, and 9.4, very close. It's between 9 and 10 injections in the first year. More patients in aflibercept and in ranibizumab groups were actually stopped, deferred injections due to success reaching dryness and good visual acuity points. However, only 15 patients, which is 1% of patients only in the bevacizumab group, that did succeed, and so injections were deferred. It shows that the two drugs are a little bit better than bevacizumab in achieving a very dry fovea and the highest visual acuity possible. How about the 2-year data in Protocol T? Well, the differences found by the end of the first year were becoming a little bit closer to each other as regards Eylea, aflibercept, and Lucentis, ranibizumab, the blue and yellow curves there. They were both showing 12 point something visual acuity gains in comparison to the stable 10-letter gain of bevacizumab through the 2 years. Also, there was no real difference as regards the proportion of patients showing gain more than 10 or 15 letters. The three drugs did not show any statistical significance in comparison to each other. How about patients who are higher in vision? By the end of the second year, it was still quite close, and no statistical significance between the three drugs was found by the end of 2 years. So the findings of the first year were stable in the second year. Again, no significant differences found between the three drugs as regards losses of letters or gain of high letters. But if we look at the group of patients who are less than 20/50, by the end of the first year, aflibercept had an edge of better improvement and more visual acuity gain. However, by 2 years, this gap was being closed with some gain in the bevacizumab group, more gain in the Lucentis group, ranibizumab, and a stable aflibercept group. And it was not statistically significant as in comparison to the 1-year data when aflibercept was showing a bit higher gain. Again, this group of patients showed no differences between the three drugs as regards the high gains or losses of visual acuity. As regards the anatomy, it was quite similar throughout the second year, with some improvement in the bevacizumab group and stability in both ranibizumab and aflibercept groups. How did the safety behave in three drugs compared to each other as regards important issues like the highest incidence of GIT events being not significant between the three drugs, all systemic events, including vascular events of any kind, was insignificant between the three drugs. Endophthalmitis incidence was insignificant, just one case in the Eylea and Lucentis groups and 0 cases in bevacizumab Avastin. The post hoc analysis, again for these types of vascular events, which was a very important question, did not show any increase in the occurrence of these events in the Avastin bevacizumab group, which was very questionable in the previous years. In summary, all types of central macular edema should be treated. Nearly all patients improve. The loading treatment never required less than 3 injections. The improvement in visual acuity means you inject more. Stability requires one final additional injection before stopping. PRN protocol is highly successful, and please do not stop treatment early, like 1 injection, and let's follow patient and see what happens. All lasers should be deferred after 6 weeks. Avastin was as effective as the other agents, and all of them are safe. Eylea had an edge as regards the end of the first year in lower visual acuity patients. However, we have to remember that Lucentis was used in a 0.3 milligram dose, and maybe 0.5 milligrams dose do different results at the end. If we look at the rise and ride extension, meaning patients who received monthly injections versus sham, no treatment, for 2 years duration, we could see that the sham group had very much lower visual acuity in the white curve. This was improved by adding in the 3rd year monthly injections to this sham group, which means they started the treatment much delayed in the course of DME after 2 years. They did show some gain within the 3rd year on monthly basis, and then when all groups were shifted to a PRN protocol, the maintenance of the high gain achieved by monthly doses from the start was achieved by the end of 4.5 years approximately, and we can see that the delayed treatment group did not show the same gain as the other 2 groups, meaning if you defer treatment in DME for long, you cannot achieve the high gain achieved by early treatment and injections. This is again demonstrated here, how the rise and ride on extension was not showing similar gains in the sham group underneath, also in the thickness drop. So retina remained thicker and could not reach the same thinning as cases treated early on in the study. So we should not really wait for that long in order to start our treatment. The Avastin doses in some countries are used in a higher dose, the 2.5 milligrams. And we advise anyone preparing Avastin to inject in the same hospital and under strict sterile conditions as regards preparation and injection. Comparing the higher dose of Avastin in the dotted line to the 1.25 milligrams in 0.05 milliliters injection dose, you can see that even the lower dose is behaving better as regards the anatomy. The thinnest retina are in the lower dose group, and very similar visual acuity gain over 6 months. You can see here the comparison at 1 year, and there is no difference as regards the dose used. So the use of a higher dose in bevacizumab patients is not really needed. It can only lead to a higher IOP and probably some AC clearance of some aqueous in order to drain some of it to lower the pressure, not to injure the optic nerve vascularity. So we definitely do not recommend using a dose higher than 0.05 milliliter in the 3 drugs. Thank you very much for listening. and we hope you benefited from this video.